why Pharm So Hard, the employees wanna find me and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Pharm So Hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Pharm So Hard.
Welcome guys back to another Pharm So Hard, Fun in the Sun. We're in Atlanta. I got a new group up here with me, the Knicks. And we're gonna be talking about the 10 drug commandments of trauma. And it's going to be good. It's going to be a little different than what we've done before, but I think it'll be pretty unique just to get a new perspective, because when I'm training my residents, they get very anxious when it comes to trauma response. And you're an ED person, so it's a little different, but my oncology PGY too, they have to come down, or someone who's interested in peds, and they have to come down for a trauma, and they ask them to like go ahead and crack open a cyano kit. That is a very bad moment. And what I want to do is just do something small for them and just talk, because I always say it's really only 10 drugs. Like you're not cracking a chest, no. You're not placing a chest tube, you're not placing a tube yourself.
You're not doing a remote. You're okay.
Yeah. So I think we're good, but we're augmenting some of those things that can happen. So I think if we talk about 10 drugs really that we can utilize and we can understand this, I think we'll be fine. So I'm not gonna pretend that ketamine isn't my favorite drug. I'm not going to pretend. R.I.P. Dr. Ingham. Ketamine, as he would say. It's a drug that can be used in so many ways. I have a patient coming in with pain, ketamine. I got a patient that needs to be deeply sedated for an ortho procedure, ketamine. We're getting ready to intubate a patient, ketamine. And the key thing I like to make sure that we're talking about the doses and how you give it for me, and you guys can tell me how it works for you guys, but the dosage and how quickly I give it, I get 3 different drugs in that same time frame. Yeah. So if I'm using the 0.3, or even sometimes when I'm using it for true pain, I can go down to 0.15 mg per kg and put it in a 100 cc bag and that run over a few minutes.
Yeah, it doesn't need a lot. And then also, some studies, looked at that, the push versus, the bag. When I was doing residency, they actually were doing a project looking at push versus bag, seeing if there was more disassociative effects or not. Unfortunately, I have to follow up, and I'm not sure what the exact results of that study were, but I knew just from experience, just looking at them, and personally, I was the one who made the drug, so I was technically an observer in a way, because I knew which one the patient was getting, how we had it randomized. So observations from me, I definitely saw that the push versus the bag won in that case if we're doing it for pain.
Yeah, and sometimes, again, I don't know about you guys, but I want a little association.
Yeah.
I want just a little bit. I always remember this coach told me, he said, Jimmy, you're a chicken nugget away from playing linebacker. And I want my patient a chicken nugget away from being too sedated, or if we could be a little over in certain time frames. But again, if I'm just wanting a patient that's been in pain, that's received opioids, I want something, getting that bag that you're talking about. But if they're getting ready to place an emergent chest tube and I want to make sure their pain is taken care of, that's when I want to go ahead and give them the IV push. Okay. And your nursing laws may kind of put you in different positions where what you can and can't do. So that's something we always have to watch out for. Yes. So anyone watching this here, my Australia crew, I don't know what you guys are doing out there.
For our Georgia listeners, that's a no-no for nurses.
So you have to kind of be cautious of what they can do and the actual intent. A lot of procedural sedation protocols, a lot of what they do is the intent of the dose and the intent of the drug puts you in procedure sedation or mild sedation or conscious sedation, all these terms we use. But again, the intent definitely does that. Yeah, so my low dose, I make a joke. I say, give me 50 milligrams of ketamine, and I can get you through almost every single case that you can. But there's some things we have to really consider, right?
Yeah.
So what's like some things that you like to tell your team, your trauma team, you tell your residents, the things we have to consider when talking about ketamine?
When talking about ketamine, I always tell them just to consider the cardiac history of the patient, just because I feel like that's sometimes overlooked a lot of times. Like, does this patient have a known cardiac history? Or visually, if they can't talk to us, does it look like it? Do they have a zipper? If they have a zipper, they've had a cabbage, so they have a cardiac history. Just because we know with this drug that, it increases heart rate, increases blood pressure. Theoretically, that flash pulmonary edema risk is there. I know that, obviously it's kind of like, is it actually a thing, or is it like, what's the actual percentage of the patients that do get it? But it's just something to be cognizant about. If you have someone with that heart history, sometimes you may be playing with a little bit of fire.
Yeah. So what have you seen so far? Again, you've been at Grady now for a little bit. You've been at Yale, so you've gotten to play a little bit, I like to say. What have you seen about, again, when you're drawing up ketamine and like how the team and how they're using it?
Yeah, so I guess in my very limited experience so far, I've only used ketamine twice now. I can count it on one hand.
Oh, man.
I know, we got to get those numbers
Pop
up.
those numbers up. Rookie numbers.
Push the ketamine.
It was both for pain, and we used 0.3 mg per kg as a slow IV push.
Okay.
And I know you were talking about, you can put it in the bag, you can push it at different rates to get different effects. Can you talk about, like, what rates you give it at for certain clinical effects that you're expecting?
Yeah, so I think for me, anything less than the minute and a half mark is where I've kind of capped it. Some people just say a minute. I know if I give a decent dose within a minute or two, I'm going to have a certain level of CNS effects. And when I do that, I intentionally do that.
Yeah, that's now you're talking about RSI at that point. Where
so
you're
it's
just
like
giving that quick push.
And it's like, you can give it, usually I can go over about a minute or so, minute and a half, and usually I get to the where I can have some nystagmus. I can have a patient that's really in a point where they can still communicate with you. And that's the difference between when we're putting these patients down with like the quick, 20-second, 10-second RSI push. That's why I find something different where they eventually get there. It's like, whoa, they can talk you through it. Man, this is weird. This is different. And I had a patient before, it's like, I'm in a car right now. I'm out of space. I usually hear a lot of out of space things. So once you push it over that period of time, you get that. So I think in 20 seconds, RSI can very quick penetration to the CNS. Over a couple minutes, I get enough to the CNS, but the doses is going to help me, and how quickly I give it is going to help me not get too deep. And then outside of that, again, that 2 to 5 plus minutes range, again, usually I'm not pushing something over 5 minutes.
Oh, no.
Again,
no one's going to really sit there for 5 minutes either.
So this is when I'm putting it in a bag and letting it run over. And some of our nurses will put it on a pump over 10 to 15 minutes.
Do you use it hang to gravity or something else?
Again, it depends. If I know that I can push it over a minute, and I know, again, depending on the access that I have, and realistically, you can calculate a drip rate if you want to be formal, but I can make sure it goes for roughly 10-ish minutes. And those are the different cases that I want to, but I tell people, you have to know ketamine if you're gonna play with that.
Yeah.
You have to be very comfortable with ketamine.
You gotta know the ins and outs, bads, what can happen, like bads, goods, because there are situations where you give ketamine, okay, ketamine's not working, what's my backup? And sometimes you run into that too for some reason for some patients, and we haven't even talked about it yet, but the good old emergence phenomenon with ketamine. So that's ketamine's kind of dark side. You have to worry about that.
Yeah. In terms of dosing, so you were talking about for pain, like more of a 0.3 mg per kg, and for RSI, like inducing anesthesia, that's a much higher dose, right?
So again, depending on what you have, again, we're talking IV doses here. I usually do mine anywhere from 1 to 2 in adults. My pediatric population, they want 2. They want bigger doses.
They seem like they need more. I think it's partially metabolism, maybe receptors with NMDA, but yeah.
But I usually get pretty good response with 1 to 2 milligrams. Again, I try to let my physicians kind of drive, like, hey, what dose do you want? I have it drawn up, but it's like, if they want to use 1 mg per kg, I'm not going to argue. If they want to use 2, I'm not going to argue. So my thing, as long as we give them enough, is what I care about. And the same thing for my paralytics that we'll talk about later on, but I really want to focus on giving enough to get the intended effect that you want. But I use 1 to 2 mg per kg, and that's it for IV. There are some unique situations I ran into, though, when I had to give ketamine IM to facilitate an intubation, where I had a thrashing patient. At that point, we had got a complete exam on him, so we knew he wasn't bleeding internally. We knew those things wasn't happening.
I knew it was safe.
So I gave him like 3 mg per kg IM, thinking to myself, I can redose at 2 mg per kg if I have to. That got the patient to where he can calm down. We got him back into the bed. We was able to get restraints on him. And then we realized at that point, okay, due to we may have to take him back to the scanner, the decision was made at that point, I want to intubate this guy. He's too much once he wakes up.
Yeah, it wakes up in the scanner, then you'll have a whole other problem. That's
if you want to piss a trauma surgeon off, have a patient doing a whole lot of nonsense
doing the worm on the CT table.
And that's how you get yourself some VEC. I'll tell you that. So you got to make sure you keep your patients sedated the best way possible. Again, what ketamine can do is it can buy you that period of time, if you give it IM, to get IV access. It can buy you that period of time to get all your equipment in the room, because if you give them ketamine IM and you set up intubation, this stuff is not set up. So that's something we have to consider.
And also, another thing to consider with ketamine too, they also call this whole awake sedation type deal. So even when you're giving ketamine, necessarily they're still going to kind of maintain the respiratory drive until you give that paralytic, which is also sometimes the nice thing about ketamine, especially when you're doing some odd intubations like intranasal intubations, which is a fun one, especially using the lidocaine, trying to get that neb up the nose and trying to do
discus,
those intranasal. Yeah, so Jimmy knows what I'm talking about.
I had
it's
hour,
like, oh, we're going to do nasal
I had
intubation.
An hour
just
intubation last week, so.
Yeah, and you're just like, oh, okay, this is going to be interesting. But.
And for these doses, the PK/PD aspect of RSI is interesting. Are you using actual body weight, ideal body weight, adjusted body weight in our obese populations?
I would love to say that I'm using adjusted. I would love to say that.
Yeah.
But realistically, in the moment, I don't have many things around me, and I'm using actual body weight. And I know I have this wide therapeutic range that I just don't think I'm going to hurt someone by giving too big of a dose. If a patient can get ketamine, I think they can get it.
Yeah, and I kind of naturally tend to gravitate, if it's intubation, like capping at 200. Just because, if you have you have the vial, it's a 10 milligram per ml, it's a 20 ml vial. I usually just cap it at 100. But the other gray area that comes out with it too is that, with most drugs, manufacturers don't study above 100 kilos because they don't want to affect their approval because their PK/PD could be wide and varying. And you usually have to rely on post-marketing data to kind of know, is this dose okay with these patients? Because sometimes we just don't know, is it just as good or not? Unless someone's looked at a separate post-market study, you just don't know.
That makes sense.
All right. I can talk about ketamine all day.
Yeah, so can I.
But
so now next up is fentanyl. We can talk about when are you picking ketamine versus fentanyl for pain control?
Yeah, it's interesting. I would say primarily my first gun is going to be fentanyl up front.
Yeah.
I like to think of my job as half my job is taking care of the patient, the other half is making sure I'm assisting the team. If I call out ketamine up front, I can get people thinking about things that they don't necessarily care about at the time. So I ask myself, what's something that I can take care of the patient? I can make sure my team can say, usually I hear 50 of fentanyl, and I can get fancy sometimes. Well, I have a large patient, I have a huge open fracture. I can get 50 of fentanyl 3 times.
Yeah, it's like, would you like 100, sir?
And it's like, well, it just depends on the team, it depends on the situation. Because I have one case when I made a big fuss. I was talking to one of my trauma surgeons. I was like, why do you guys always just get 50? And it was like, you can drop the pressure. And I was like, it's probably the trauma itself. But the one time I said that, I gave 100 my patient pressure tank. And I was like,
yeah, it's like you try that. It's like, oh, let's try 100 this time. And then it's like, it's like, sorry. As you're just like this. Surgeon's giving you the side eye.
So again, I try my best to fitness my go-to. Cause I know exactly what I'm getting. I know how to take it off if I have to. I know I'm buying myself 30 minutes to an hour. I'll probably say, realistically, probably 20 minutes to an hour, 20 minutes to 45 minutes of a good pain once I get the dose that I want. And we all know about the respiratory depression that we can be associated with that. I've never, and we have a lot of experience here. Have anyone in the audience ever heard of seen chest wall rigidity?
I've only read about it. Yeah.
No, again, this is
even with those studies. I think it was really like those cardiothoracic patients that were in the OR for hours, getting these massive cumulative fentanyl doses that it really happened. Yeah. I've never ever seen it. Yeah. I've given up to even we were still kind of doing pre-treatment a little bit for RSI, giving 300 mics, no problem, no chest wall rigidity.
Yeah, so. I just haven't seen it. Again, I remember I got pimped on that one time on rounds, and I was like, I'm going to make sure, if I ever find a patient, I'm going to reach back out. But every time I go a year and I push 200-300 administrations of fentanyl, never got it. I go from there. So that's something that's, I call it the lexicon pharmacist, and of course someone went and said, the lexicon pharmacist will tell you can't do that. Because on lexicon, they read and say that's what it is. So I'm not necessarily sold on that. From a hemodynamic standpoint, I want to caveat again, in most of these patients, if you have a patient that's fighting for their life and bleeding, those people can drop blood pressure because the only thing that's keeping them is that drive. So in the acute phase, I make sure I'm very cautious with what I do. Okay. But I think of everything as after the primary exam is done and we get back from CT, I pretty much, for the most part, my team usually knows whether they're going to the OR or if they can kind of stay and play downstairs. And those are the patients that I'm not as concerned about their blood pressure dropping. But again, I've learned now to be very diligent with making sure my team's getting ultrasounds, making sure that they're getting the imaging that they want. And my trauma surgeon can say, hey, I don't think this patient's bleeding. And usually very quickly. Yeah. Okay, the interest level, it goes from, wait, get the secondary, get the tertiary, I'm out of here.
Yeah, it's then there's the attending's bye, go into the OR.
Yeah, so those are the patients that once they, again, for the most part, and there's caveats, and trauma is trauma.
Yeah, just always keep an eye on your systolic. If you're giving that dose, just keep an eye on the repeat. Because sometimes, you may or may not be looking, or they go to CT scan, how many people are looking adhering closely at the blood pressure.
And with all drugs, you should do is put communication, because this is what happens when you get pharmacy involved, you have nursing involved, you have everyone there, and the patient's yelling they want pain meds. It's like, okay, wait a second. Hey, did you get the fentanyl?
Did you give it? Did you give it?
And then, like, what happens with the remaining, because usually most vials are 100 mics per 2, that, again, we see commercially now.
Yeah.
You pull up your 50, give it, hand it to the nurse that's documenting. Another nurse goes, that's bedside, pulls another 50, and you go back and forth, and you have issues when it comes to waste.
It's all applicants could tell. Who's on first?
Yeah.
Who's second? I'm on third.
Yeah, so that's my big thing with fentanyl. Again, great drug. I traditionally dose mine 0.5 to 1 mic per kilo, and I vary from that. We know it's going to be an opioid antagonist, but it's like all these things we have to make sure we're focused on as far as all the caveats when it comes to trauma in particular.
Especially when there's multiple traumas going on, I can't stress the importance of that because, you know, like even when I'm pulling something, I always tend to slap a patient sticker on the vial so I know like who belongs to who, because I've been burned a few times where it's like, whose fentanyl is this and who do I have to waste it on? So.
Or you go home and you reach in your pocket and
Oh yeah, that's the like
But that's been
like, I swear,
Yeah.
it's a mistake.
Going back to RSI, so we have 2 paralytics that we mainly use. In trauma, I don't know, do you reach for one over the other?
It's tough, man. I'm gonna say this. I've seen, depending on where I practice, my docs would go more towards rock because I usually hear the case. I don't know the patient. If I don't know what's going on, the patient's been down. We get these random patients. Now you have an MVC from the scene that's a little different, and you can go with something that's quick.
Yeah.
But I've seen, again, my group again start to gravitate more towards that, and I think rock is an important drug, not necessarily because it's better, but I think that from a pharmacist standpoint, it's important because there's some caveats in there that we have to be aware of to make it the best.
Yeah, and it's like, you know, and TAPL, and I can't stress this enough, every time I do my topic discussion with my students and residents in RSI, I just remind them, okay, what's the half-life of etomidate? Okay, what's the half-life of rock?
Yeah.
Okay, and then everyone's freaking out 15 minutes later, oh my god, the heart rate's 130, the patient like must be going into shock or something. And I was like, no, the patient's just awake but paralyzed.
Yeah.
So
That's
that's what's
something
going
that
on.
ED awareness trials are really, I think, important to stress to learners in the ED. Every time I have the chance to talk to either interns or other residents or students that are rotating, I kind of try to make the point, we're intubating with etomidate and rock. What are some points that you'd want to consider? The awake while paralyzed is really something that could be really traumatizing. Speaking of trauma, being awake while paralyzed.
Double trauma.
Yeah, double trauma. So I guess, do you have strategies for reducing that kind of trauma?
Absolutely.
Or in dosing strategies for certain populations?
So I've been fortunate to work in shops where when we're getting ready to intubate, I'm usually called to the scene and they know that it's the RSI medications plus the post-intubation sedation.
Yeah.
Okay.
So for 9 times out of 10, every patient that we're intubating gets fentanyl after. Like immediately after. I check 2 blood pressures, fentanyl. That's like my go-to every time. 2 blood pressures, get fentanyl, and then we can add on the sedation from there. And it really just drives me to, hey, okay, I know you're setting up your MAC. I try to be very conscious of what my providers are doing, but hey, what's your plan for after? If you ask that, and we actually have studies that was done by Johnson and colleagues, I think in 2014, that showed when you had an ED pharmacist there, you actually increased the time to analgesia by I think like 40 minutes.
Yeah, wow. I remember that study.
40 minutes, and you increase sedation by I think 30 minutes as well. So we're there to do it. We have the data to do it. That's kind of my big caveat. And know if you need a neuro exam.
Yeah, that's a big, especially, with neurotraumas, you're just like, well, we just did that, so I guess, you're going to have to wait a significant time for it to wash out. And, always have a backup plan. What was plan A? Okay, now what's plan B? Always think in your head, like, what's the vitals now? Okay, something, happened, intubation, patient decompensated. This was my first plan. Maybe I grabbed it already, but don't prime it yet. Because didn't whole dose waste. But then, okay, what's plan B? And then,
what is your, strategy for managing reversing rocuronium if you need to? Like, say you don't know the patient, but you need to paralyze them, so you give them rock, but you need that neuro exam soon too.
Yeah.
Are you reaching for something like Sugamidex or something like neostigmine?
So it depends. I would say how urgently do we need that? And my neurosurgery colleagues, they do a good job of saying, hey Jim, I'm gonna probably be down there in 10-15 minutes. In that case, before we're even going into it, I'm calling Central Pharmacy to give me some like neostigmine and atropine. Now, if the case is kind of rough and things are going on, I try my best not to use Sugamidex. In certain places, it's been challenging to even get it. Like, or it's only stocked in the OR.
Yeah, it's just like such like, oh, this is OR only type
Yeah.
item, you know. And then also it begs to differ, you know, sucks versus the whole rock thing.
Yeah.
You know, what sucks, you know, is the whole controversial ICP
Yep.
increase, which, you know, goes back and forth, you know, between that. But, you know, sometimes if you don't know or do a neuro exam, that's might be that maybe niche area where maybe sucks could be a little bit better, just because, you know, it's going to wear off quicker and they can get that.
Yeah.
You know, that's why it's like, I feel like my shop really tend to like gravitate a little bit towards more sucks. And then afterwards, if we're having trouble and we're like maximizing sedation, then we may toss in like a one-time dose of Rocuronium just to get them calm enough so they can get scans, but also keep them sedated on the table.
Yeah.
But, you know, it depends how bad they want that neuro exam.
Yeah. Yeah, that's rock.
Okay.
Yeah.
Next, we're kind of switching gears a little bit, talking about antibiotics. So what are kind of your main antibiotics that you use in trauma resuscitation?
This has been cool lately. I think over the last 5 years.
There's been a lot of updates in open fracture prophylaxis.
It depends on where you're at. So again, I remember I made a song and I was like, scratch the gent, let's get on with open leg.
Yes.
Because I'm no longer big on giving gent. And I worked at a shop where we had to compound gent at bedside every time.
Wow.
And not just for regular trauma open fractures, all your finger amputations, all those things. I had to make all those, and I asked myself, like, where did this data come from? And me and Rob Connolly did an episode on this a while back, and we're talking about like guidelines and stuff that was done like in the 60s and 70s.
It's like everyone keeps asking where else what we've always done.
And
you know,
it's
this is what my person did, and I was like, where is this actually coming from?
And then you look at the guidelines, it's like extensive gram-negative coverage.
Mm-hmm. Yeah, which it's just like, oh, great area, thanks.
Yeah. So again, I'm big on my grade 3 open fractures, and then same for my grade 2s. Having my gram-negative agent is going to be my Rocephin, 2 grams by itself for the most part for our decent-sized patient.
Yeah.
Now, depending on, again, we're going to be in that grade E, you see something a little different. It's not only ceftriaxone against for your general one. You have to add on some MRSA coverage as well, because again, some of the studies we may see that MRSA is rising a lot higher.
Yeah, it just depends on your patient population area too. If you see high MRSA rates, then you do have to cover it, you know. And interesting enough, there's actually a really interesting, I think it was like a physician paper by a group of physicians where they talked about open fracture prophylaxis, and that's kind of where we based our current ones on with the Rocephin and the vancomycin, which, you know, I know it's just kind of like the doctors did this position paper, but I think it's fascinating that maybe this should be like elevated to like, you know, actual guideline level. And one of the things I want to do is that since we just changed about a year ago is kind of look back, was there a difference in, you know, infection rates too? So,
and I think we have a decent amount of data now. I think some folks down in Lakeland did a study not too long ago and looked at, again, the different rates, things of that nature. But again, Rocephin is now my driver when it comes to my nasty ones. And I tell my orthos, my trauma, they said, Jimmy, how do you know which one to give? And I say, if you see bone, give ceftriaxone. And it's just easy. See bone, ceftriaxone, and I go from there. The next one, again, I want to kind of push us ahead in time here, is going to be ANSEF.
The life-saving ANSEF.
ANSEF,
don't forget the
we should put those
And
together.
tetanus.
yes,
I should like to
saving
know
tetanus.
Yeah.
Don't forget the tetanus.
It was an honorable mention. It was tough, but it was there. But the key thing about ANSEF, sometimes we have to remember, is that some of the dosing can be interesting. If I went back and when I did the episode with Rob, I noticed that, again, in patients less than 70 kilos, certain guidelines can say you can give 1 gram.
You can get away with it, possibly.
So that was intriguing for me, because I've always been taught, 2 grams. And then if they get above that 120 kilos, add them to be at 3 grams.
Is there risk with giving 2 grams in smaller patients?
And that's
I like, to be honest with you, like, I think it's most prophylactic just for 24 hours, right? Because they want that closed within 24 hours. They should be going to the OR if they open fracture. So if you're talking about, obviously everyone's worried about beta-lactams and the renal risk associated with them, but you're just giving ANSEF and you're giving 3 doses.
Yeah.
Unless, the minor caveat with that is your oddball dialysis patients maybe, or someone who's having some really bad renal insufficiency issues, then that might be a little bit different. But even then, just 3 doses, you're not going to get beta-lactam, like neurotoxicity or anything like that, or renal things with it. So,
okay. That's my big thing. That's my big thing with ANSEF. Again, realizing, one thing I didn't mention is that a lot of ED shops are moving to IV push. ANSEF, Raxone, and we may be speeding up our times to get, because again, the goal is 1 hour. Certain shops actually have a time of 30 minutes they want to get these antibiotics in. Yeah. So we want to make sure, what's the easiest way to do that? Pre-mix or IV push?
Yeah, so I think that hour is actually a standard. I think it's a trauma standard. I could be wrong, anyone in the audience might be wrong with that, but I thought that was a trauma standard hour. Yeah, it is a quality metric. Yeah.
So those are my big antibiotics. Those are the keys to the treatment.
Right. And Antiph has that unique side chain too, so even people with some beta-lactam allergies, it may not be as high of a risk.
We studied this too.
Most penicillin allergies
are
are
bogus.
just kind of like,
Bogus.
most of them. But then you have that one Goldilocks patient that comes in,
And mess up your entire.
and it happens to be a trauma patient that's a little bit unstable, and you give them Antiph. But that's why everyone's kind of nervous about that whole thing. They might hop the Clinda, just because of it.
Yeah.
Clinda.
I know Clinda.
Well, we can't get into it, but
You smell C. diff? I smell C. All right, what you got next for me?
next, we're going more towards blood products. We got calcium salts upcoming next.
Oh man, I love this, man. I love this. Again, one of my colleagues down in Orlando, they did a study where they looked at patients what was their initial calcium level when they had trauma, and a significant amount, over 50% of these patients, again, in their population, was hypocalcemia at baseline, at the door.
At baseline,
at the door. And then after, again, it gets pretty tricky here. Every 2 to 4 units of blood that we give, that citrate that the blood is going to be pulled in can further reduce that.
Yeah.
And this is the problem that I have with calcium. I think we should give it. I don't know the dose. I don't know the salt, but I think it's something that we should give, and it's something I'm teaching my residents to do.
Yeah.
But I don't necessarily know, because my colleagues from Orlando Health, they did 3 grams of calcium chloride. And I was like, okay.
Yeah, you can do some research out there, different MTP protocols with different hospitals and different universities, and it kind of varies. Like, no one really has a solid position on how much calcium should you give, how much is too much, how much is bad, and how much is good. Yeah. It's still a gray area, but one thing they did say though is that just be careful. Too much can be a problem, so you do have to worry about that. But how much to give, it's a question mark. But the best way, and I've seen some papers actually kind of guide this, is trying to get those calcium levels if you can, which I know is difficult if you're doing an MTP situation. But if they're sending off some blood, getting an ionized calcium, and kind of figuring that, using that to kind of guide treatment.
And are you usually giving an IV push? Or are you hanging in a bag?
Yeah, it depends what you have. I've seen it. I've been in different shops where they've had a pre-mix ready to go, and I can just get a 100 cc bag and let that run. The problem I run into is I don't necessarily have access all the time.
Yeah.
If I got a Cordis and my trauma team want to give blood, I'm not playing around and letting something run over 10 minutes.
Yeah, no,
The same thing with tips. I just don't have the time. I'm gonna get this as a push, and realizing that the risk of this patient again continuing to bleed may be a little bit. The risk of that not as bad as the necrosis that potentially can happen.
Yeah. It's also if you're pushing it through a large bore, even if you have access to it, you don't really even have to worry about that anymore. It's mute at this point. If it's obviously if it's a Cordis or central line, perfect. Even if it's a really good peripheral. Some peripherals are 16s. Especially in trauma.
Yeah, so you get these nurses out here now, man. If you work at a busy trauma center, they can put a 16 in your toe. Yeah. I've seen IVs in the breast. I've seen it everywhere, man. They're phenomenal. You can get you a good IV. So my big thing is just realizing the action team, hey, if we go this route, can I go ahead and just give calcium after you get to units? That way, no one has to say anything about it anymore. I kind of do my my briefing for the case, and then I add on at that point.
Okay, that's smart.
I tend to get a little bit nervous about the foot IVs though.
Yeah.
Especially when you're pushing something as hypertonic as calcium. Because I've seen a hand actually get necrotic once from not calcium but dextrose, and they pushed it in blue. And
wow.
All right, what you got for me?
Next up, speaking of blood products, is Kcentra.
Oh man, this is intriguing now, man, because depending on, again, most of the times you have probably the most common, and someone can fact check me, is your level 2 or your level B, whatever it is. They're the trauma because they're an old person that failed.
Yes, so the good old ground level fall.
Mima fell.
Mima fell on blood thinners.
And they come in and they're either completely out of it and they need to go for the type of urgent procedure, which I'm a little bit more aggressive there. And depending on which anticoagulant we're talking about, are we talking about warfarin, are we talking about our DOACs, are we talking about any of those, my dosing changed quite a bit. I'm on the fixed dosing kind of band.
Yeah, we actually recently, as a system also at my shop, changed the fixed dosing as well recently.
You guys do 1500?
1500, and then for neuros, it's DOAC 2000.
Okay.
Yeah.
And that's kind of my thought process. Again, I think some people are still using the 50 unit per kilo, and I like to make mine bedside. Even if it can't come from pharmacy, I'm just that person where I want to control the whole process. And we looked at this before, and we had a quicker time to get it in the patient, but if I'm working somewhere and I'm allowed to, I'm giving my
Yeah,
days.
and it's also logistically too. You know, sometimes it may just not be feasible. You know, because one thing you have to be careful with is that if you're setting a standard of practice, you want to make sure that you can maintain that throughout the thing. So if you're there,
just talking about this today.
it's just like, if you're there doing it, great. But what happens when you're not there? Who knows how to do it?
Yeah.
You know, and that's the big thing you have to realize. It's like, oh well, we just lowered our standard of care for these 8 hours that someone's not there.
Yeah.
So that's something to be cognizant about.
Yeah.
But you know, Kcentra, you know, interestingly enough, while we're talking about it, you can talk about the whole controversies with that and Dexa that's out there, which everyone's going to go back and forth about that one.
That's an episode. That's
An episode in itself.
Yeah.
But you know, key pearls I would say with Kcentra, just remember those rare patients that have a history of HIT. That, you know, there is some heparin in that Kcentra, so you have to be cognizant about that. I know sometimes you may not have that data, but if it happens, if they're in the EMR and you can maybe see that, or if they're being transferred from another hospital, just be, you know, aware of that and just look for that.
What are your other options if someone does have a history of HIT and they need to have anticoagulation reversed, or they have, you know, severe bleeding? What are you reaching for next?
What do you have? Formula is the question.
Yeah, the question is, you know, I'd have to double check, and someone can quote me this wrong. I haven't used FIBA in a long time. I don't know if
You like
FIBA,
FIBA, right?
does FIBA have heparin in it?
No, I think FIBA doesn't. And what's the other one you guys used to have?
Babylin?
Yeah, I thought that didn't happen as
Is
well.
that 3-factor?
I think
Yeah, it's 3-factor.
Which isn't as great, obviously, but theoretically, the oldie but goodie is FFP. Which,
Yeah,
you know,
you're most likely going to give it to a lot of these patients anyway, but I think you just realize where your INR is going to end. You get 1.5, 1.6 and have that conversation.
Makes sense. Next up, another age-old debate: Mannitol versus hepatitis
I love it, man. I got to speak to Morgan Jones, who was the second author of the cerebral edema guidelines. We went back and forth about this. And I'm a hypertonic person. It's just how I train. It's the easiest thing for me to give. I just throw it back up there, let that back run wide open, and I'm good to go. And based off, again, some weak data, again, the data is not super strong, but it seems that you get a reduce and rebound, interest, ICP increase, and you get a longer duration. So I like to keep myself.
And it kind of makes sense based on at least mannitol's structure and its ability to get into the intraparenchymal space and retain some fluid there. It can cause that rebound that you were talking about. Are you giving 3%, 7.5% bullet?
I think it really just depends on what you're working at, where you're working at, how comfortable they are giving it. Because just remember, the bullets at 23.4%. If we're talking about high risk meds, this is the highest you can get. Because this is something that's seriously dangerous. If you give this in the wrong IV place, if you give this, possibly too much or too little, it can have some serious complications. So that's why, it just depends on where you go. If you're talking about, simplicity and easy, you have 3%, but then again, that's all that extra volume that you have to worry about versus that concentrated sodium at 23.4%. At my shop, it tends to not to be rush with, the hypertonic. We'll put the orders in, obviously they'll get the central line and start the hypertonics, usually all downstairs, maybe in the trauma bay, or maybe when they move them to a room. Is that they're super emergent, they're going up to the OR for a craniotomy anyway, so you're not even have to worry about that. But usually I have enough time when they get that central line and they'll do 23.4%, alternating with acetate and chloride every 2 hours.
Yeah, that's the big thing. And some docs can prefer mannitol. I used to have a hate relationship with mannitol, but I've kind of taken an approach back talking to Morgan. So we have the bags now, and again, we can warm those bad boys up and make sure we put those crystals.
But be careful though, because we ran into something interesting when we had our joint commission inspection about keeping vials warm all the time.
Yeah.
Supposed to warm them until
only when needed. It's there's that whole controversy, and then it's is your Omnicell in a cold room? Because then you're gonna realize that when you need it, all your mannitol bags have crystallized in the Omnicell.
And that's the challenging part. And again, I'm not a fan because I still used to filter. I go through the whole process doing that, and it's just not quick to me. The data's not there, and it's just again I didn't train that way, so at least I'm not as negative on it anymore. But again, I'm a hypertonic guy. I'm a 3%. Open the drip and go from there.
And then with mannitol, you also have to be careful. Just think mannitol is like an osmotic diuretic.
Super diuretic.
So you better make sure they have a Foley or something in place, because waterworks are coming. So you give that dose,
and your nurse
prepared. Nurse would be like, "What is this?" It's then there's a whole leader. It's just you're gonna help change the sheets with me.
And they, you know where you're at.
Finally, we have a cyano kit.
Yeah,
Roscoe Bauman.
It's on here because I had a case that I would never forget where I couldn't find the cyano kit. I thought it was in Central with coding the patient. Again, I thought in my head it was somewhere else, and I realized the importance of making sure you know exactly where it's located, knowing how to compound it, and the indications for that because it's just wide open. You have
or using for cyanide toxicity, or using for refractory hypotension.
So most of mine are going to be cyanide. Again, a burn patient that comes in, comatose, hypotensive, soot in the nose and in the back of the throat. Those are the patients who I see, but again, I'm having it available for every burn, and then I'm gonna let my teams tell me how to drive, whether they want to use it or not.
Yeah, and just, it's important being aware of it. And also, there was a huge global problem with it not too long ago where no one could get it.
Yeah.
And then you're talking about what were the old school stuff. So then you're talking about the old school cyano kit, amyl nitrate, sodium nitrate, and sodium thiosulfate. No one really makes the amyl nitrate ampules anymore, but it's called methiodote is the combo product you can buy, which you have to jump through some hoops to actually get it and get it in your ordering piece. But I actually had to keep one because we ran out of it. We're not a burn center, we always keep one just in case we do get those occasional random smoke inhalations in the wintertime. And I was like, well, I have to get this, but then I have to put a huge huddle note out about it. Because you have to remember with most burns that come in, you're not only dealing with cyanide but also carbon monoxide. And the key thing with sodium nitrate is that it actually induces a methemoglobinemia. And if you give that to someone who also has carbon monoxide poisoning, you may have just given them a death sentence.
So watch out for that, man.
Yeah, and in the cyano kit, actually, I think there's a little card that gives clinical pearls about how to use it. So if you've never used cyano kit before, there's information about how to use it on a little card in the box.
Yeah, I think the weirdest thing about it though, it's 200 mLs of normal saline. It's not just a 250. It's not whatever. You could be risky and take this spike bag and just pull it out right at the right second. Or as you just pushing 50 in there and getting that 200. But just know, obviously, since they have that cobalamin part in there, it's kind of like B12. It is red. It will turn everything. Labs first, another key caveat too, because it will affect, all types of labs and possibly even blood gases too, or even if you're trying to get a, what's what I'm looking for? Blood gases, where they differentiate the blood gases. Is it calorimetry where they do it, the different types like carboxyhemoglobin, methemoglobin? I forgot what that call is, but it's a certain lab. But beside my points, it will affect that as well, so it can make things tricky.
All right, man. You got yourself the Bible, the trauma commandments from a pharmacy standpoint. Thank you guys for joining me. Thank the audience for joining me. Any comments, questions, issues when it comes to the drugs that we're using? Again, Technus was on there, but I couldn't necessarily put it on there to go from there. But if you guys don't have anything, thanks for coming on. And we end the show. We get everything the same way. You don't have to be a pharmacist. You don't have to work in the ED. But everything you do, make sure you Pharm So Hard.
Yeah.
Perfect.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.